Hello, my name is Dr. Liam Brennan and I am a consultant anaesthetist and Deputy Medical Director at Cambridge University Hospitals. I'd like to tell you a little bit about the impact the Covid-19 pandemic has had on the Trust and how we have met that challenge. Initial reports of this new virus emerged from China in late December 2019, with the first UK cases reported in York at the end of January. The first case was admitted to CUH on the 11th of March, and this coincided with the start of the rapid rise in case numbers across the country that culminated in the lockdown announced by the Prime Minister on March 23rd. To give you some idea of the impact the pandemic has had, at the first wave peak in mid-April 2020, we had 135 inpatients, of which 45 were in intensive care requiring respiratory support. In respect to the Trust's response to the pandemic, we started to hold informal meetings towards the end of January. We set up assessment pods for COVID testing in early February, and by the 4th of March, Public Health England and other NHS agencies had declared the incident as a level 4 infection control incident with all of the changes in practice that entails, as we will come to. On the 11th of March, the World Health Organization declared the worldwide incident as a pandemic, and we set up our formal command and control structures here in Cambridge the following day, which we will describe shortly. This guided our response to the pandemic through the intervening months, but by mid-June, the numbers of cases had started to fall, and so the incident was downgraded nationally to a level 3 infection control incident. So with respect to the CUH response, we have been managing the pandemic as a rolling major incident with gold, silver and bronze command structures. Gold Command consists of members of the Trust Executive Board, including the Chief Executive Officer, the Chief Finance Officer, the Medical Director and the Director of Nursing. They are overall responsible for the Trust response and for setting our strategy. Silver Command consists of a triumvirate of senior medical, nursing and operational leaders who are responsible for enacting the strategy which has been dictated by Gold Command. And they are available 24/7 to steer the hospital through the pandemic over the past months. Beneath Silver sits a series of bronze commands to enact the various responses across the whole of the hospital. And these include the workforce, infection control, personal protective equipment, estates and facilities, our divisional structures, emergency department, and all importantly, communications. This slide just emphasises the points made previously, but also makes the point that in setting up our gold, silver and bronze structures, we were following national guidance and ensuring that we were compliant with legislation, including the Civil Contingencies Act. Ensuring that our staff were safe at all times during the pandemic was our top priority as an organisation. Personal protective equipment, therefore, took a very high prominence in our planning and in our strategy. It is true to say that maintaining adequate supplies of PPE were challenging in the early stages of the pandemic as the NHS supply chain matured in its response. But in partnership with the supply chain, plus independent purchasing of PPE through our brilliant Trust procurement team, we never at any stage ran out of any item of PPE during the first wave. We followed PHE guidance with some enhancements, and these include the use of surgical scrubs in the COVID positive areas where patients are managed around the hospital. We developed a scenario approach with supporting infographics and videos, and an example is shown via the link here, with online and face-to-face, appropriately socially distanced education sessions to embed good practice amongst our staff. This was supplemented by developing a network of local PPE champions with regular audits of PPE practice. Here are examples of two of the PPE infographics which we developed. Scenario 1 refers to the appropriate use of PPE in COVID positive areas on ward-based facilities around the hospital. It shows the core PPE that our staff should be wearing, the appropriate donning and doffing sequences, and the emphasis on the use of eye protection and hand hygiene at all stages of the process. Scenario 2 refers to the management of the use of PPE in COVID positive areas, but this time in the higher risk areas where aerosol generating procedures are performed, such as tracheal intubation. This is mostly in the operating theatre and intensive care units, because we know that in these areas, aerosolization of the virus is a much higher risk, and therefore enhanced levels of PPE are required, including the use of FFP3 masks as respiratory protective equipment. Ensuring that we kept a very close eye on our PPE stock levels was important throughout the first wave. And early on, we developed a traffic light system for key core items of PPE that was reported on a daily basis. This slide shows an example from late July, by which time we had a very healthy supply of PPE, showing all items in the green zone with only one in amber. The other thing to emphasise from this slide is the scale of the PPE procurement exercise and delivery exercise that was required across the organisation. You can see we hold enormous stocks of PPE, and on this slide alone, we're showing the stock levels of well over 1 million items of PPE held by the Trust. To give you an example of the amount of usage, we are currently using around 30,000 surgical face masks a day, 20,000 aprons, and over 1,000 FFP3 masks. Very early in the pandemic, we had to suspend all inpatient elective clinical activity in order to create bed capacity to manage the influx of COVID-19 patients that was expected. Throughout the pandemic, the emergency caseload has continued, and we have maintained an element of urgent surgical and other clinical activity, mostly cancer work, prioritised by an independent expert group following national guidance, with decision-making underpinned by the Trust Ethical Committee. We have been able in recent weeks to increase our capacity for urgent surgical and other activity, and so currently we are back to around 70% of normal operating theatre capacity. However, face-to-face outpatient activity has continued to be severely curtailed and has been replaced by telephone and online consultations wherever possible, which generally speaking have been well received by staff and patients. In order to manage the COVID-19 workload, the hospital was reconfigured to designated areas. Red for confirmed COVID positive cases, amber for where the COVID status was unknown or equivocal, and green where the patients had been confirmed as COVID negative. The bed envelope in the amber areas had to be contracted to allow for appropriate social distancing, 2 metres, between patients, as the hospital lacks an adequate number of side rooms for isolation purposes. Our critical care capacity has trebled to potentially be able to manage around 100 adult patients if required, although so far, at the peak of the first wave, we never had to use more than 70 of these beds. Along with the bed reconfiguration, our medical staffing was also reconfigured to ward-based team approach, led by a consultant physician providing 24/7 cover. Staff movement between red, amber and green areas was avoided to minimise nosocomial infection, which thankfully has been relatively low in the Trust. And I'd like to highlight in particular that anaesthetic and operating theatre staff were redeployed to support the critical care surge capacity. Ensuring our staff health and well-being was another one of our top priorities during the pandemic. It was recognised early on that Covid-19 had the potential to directly and indirectly harm our staff members' physical and mental health. We developed an occupational health risk assessment tool to stratify individual staff risk profiles on the basis of if they had any existing medical comorbidities, their age, over 55 being important, and if they came from a BAME background. The most vulnerable staff were diverted away from working in red amber clinical areas, with working from home facilitated in particular for non-clinical staff. Sickness rates have been closely monitored, which have been relatively low in the Trust, and psychological support was instituted and offered to those who needed it. Patient and staff testing was initially very limited and confined to suspected cases only. But as capacity has grown, our Trust-wide COVID swabbing approach is now available for all suspected cases and admissions to the Trust, all patients before discharge to care facilities, and for staff and patients as a surveillance tool. The existing Public Health England lab testing capacity has been supplemented in partnership with Cambridge University and pharma industry and has been one of the great successes of the pandemic so far. An antibody testing programme has recently been initiated, and point-of-care testing for emergency admissions is available with a turnaround time for results of 60 to 90 minutes. Communications, both internal and external, has been essential during the pandemic. Internal communications to ensure our staff are kept up to date with the rapidly developing knowledge base about the virus and our changes in policies as a result, with daily updates to all staff via email, supplemented by weekly overviews from the Trust Chief Executive, with Facebook Live Q&A sessions and podcasts, a staff Facebook page, and a dedicated staff information portal on the Trust website. Externally, we have used social media extensively, with interviews for print, radio and TV at local, regional and national level, with lots of coverage from the BBC. So in summary, the COVID-19 pandemic has, by everybody's account, has been the most serious threat to global health to occur in the past 100 years, and certainly the biggest threat faced by the NHS in its history so far. CUH has weathered the first wave generally very well, and this is really very much due to the magnificent response from staff across the whole organisation to the challenge that the pandemic has produced. I suspect really one of the biggest challenges that we have faced is restarting non-COVID clinical activity alongside the COVID caseload. And this has been further magnified by our ever-present risk of a second and subsequent waves of the pandemic. Thank you very much for listening.